So now what I'd like to do is introduce our first keynote speaker, Crick Lund, for his talk, which is called Interventions to Tackle the Social Determinants of Mental Health Among Young People in Low and Middle Income Countries, Challenges and Opportunities. Crick is a professor of global mental health and development in the King's Global Health Institute, Health Services and Population Research Department, Institute of Psychiatry, Psychology and Neuroscience, King's College London, and honorary professor in the Alan J. Fisher Centre for Public Mental Health, Department of Psychiatry and Mental Health, University of Cape Town. I'm looking forward to Crick's talk, and I'd like to welcome him here now.
Hi, my name is Crick Lund, and it's really a great pleasure to be with you today, speaking at the Early Intervention in Mental Health Conference. And the topic of my talk is on interventions to tackle the social determinants of mental health among young people in low and middle income countries. And I want to highlight some of the challenges with this whole area, but also what I think are many opportunities for addressing really key unmet needs for young people, especially in these countries. So here is an outline of my talk. I'm going to begin by giving a bit of background on recent developments in mental health care in low and middle income countries, and really the growing evidence base, really a burgeoning area of research on providing treatments for mental health problems in low and middle income countries. I'll then turn to address some of the challenges of the social determinants which often drive mental health problems in these contexts, and how this is really a key and I think a very much an overlooked area which really needs our attention as a global mental health community. I'll then set out a framework for the social determinants of mental health and provide some key definitions based on some of the work that we did as part of the Lancet Commission on Global Mental Health and Sustainable Development. And then I will set out some of the opportunities for addressing social determinants, opportunities for intervening, but also some of the challenges that we face working in this area. And then I'll conclude with some current examples of research projects that we have in this field of the social determinants of mental health in low and middle income countries, and then set out what I believe is an agenda for future research and for policy action. So it's a very exciting time to be working in global mental health. Since around 2009, 2010, when WHO launched its flagship MHGAP program, there's been a growing impetus and support for providing treatments and scaling up these treatments for people living in low and middle income countries in particular. And this really began with WHO and Wonka producing a publication on integrating mental health into primary care, which outlines some excellent case examples of innovations in this area. Then the MHGAP program was launched in 2010, and the MHGAP intervention guide, which was then subsequently updated, has been used extensively, and it's now in use in over 100 countries around the world. These provide really strong evidence-based guidelines for how primary care practitioners can provide basic care for people living with mental, neurological, and substance use disorders. And these are really huge steps forward in the field. MHGAP has also been accompanied by the publication of an operations manual, which provides a planning tool for the rollout and scale up of mental health services in these settings, and has also developed an MHGAP community toolkit for providing community-based mental health services. So these are really significant developments in the field, and they have the potential, and indeed in many cases have already provided some much needed mental health care for people living with these conditions. And supporting this broader WHO agenda has been a burgeoning area of research in the field. And on this slide, you can see the logos and the titles of many of the innovations over the last 10 years in mental health treatments. And these have included very rigorous randomized control trials, implementation science work. They also include interventions that address a wide range of mental, neurological, and substance use conditions. And this is really just a few of the programs that I'm aware of working in this field. So it's been an exciting time, and there's a huge amount that's been developed in terms of the evidence base for what works, for whom, how much these interventions cost, and how they can be scaled up to narrow the treatment gap for mental, neurological, and substance use disorders. However, all of these interventions face significant challenges related to the context in which they are delivered. And I'm showing you on this slide some photographs from Khayelitsha, which is a large peri-urban township settlement on the outskirts of Cape Town in South Africa, where I am based. And this is a context which is very similar to many of the growing urban slums which characterize the large and growing urban settlements of many low and middle income countries. Now, from 2011 to 2016, we conducted a randomized control trial in Khayelitsha called the AFFIRM study, the Africa Focus on Intervention Research for Mental Health. This was listed in the previous slide. And our goal here was to evaluate the effectiveness of a task-sharing psychological treatment intervention for perinatal depression. And in the formative research, we encountered many women who met the diagnostic criteria for depression and were enrolled in the trial, but whose experience of depression was completely intertwined with their experience of social and economic adversity. So often accounts of depressed mood would be related to and linked to stories of inadequate water and sanitation, poor housing, as you can see in these pictures, high levels of inequality, with South Africa being one of the most unequal countries in the world, high levels of violence, especially gender-based violence, food insecurity, which was rife in this community, high levels of unemployment, and also migration. Many women had migrated to the urban setting of Cape Town from the rural Eastern Cape in the hope of finding work. So many of these social and economic factors were really driving what women experienced as depressed mood. And it was often very difficult to disentangle depression from these social drivers. Now, when you look at the epidemiological evidence, it actually bears out many of these women's experience. We conducted a systematic review back in 2010, asking the question, is there an association between common mental disorders like depression, anxiety, and somatoform disorders, and poverty? And we found in the majority, indeed the vast majority of studies, these were 76 community-based studies, there was a statistically significant positive association between diverse measures of poverty and common mental disorders. And this included increased prevalence, increased severity, longer course, and worse outcome. Poverty was also associated with higher rates of common mental disorders across rural and urban areas and across age ranges. So really quite a strong and consistent picture that social and economic adversity really shapes the mental health of populations. So this leads us then to the question of how do we understand these social determinants? So first of all, how should we define them? And then how do we make sense of what is a complex array of interacting factors? So as part of the Lancet Commission on Global Mental Health and Sustainable Development in 2018, we published this systematic review of reviews looking at the social determinants of mental disorders. And here we define social determinants as the social and economic conditions that have a direct influence on the prevalence and severity of mental disorders in males and females across the life course. This includes three important features. First of all, the structural, social, and economic arrangements which confer advantage or disadvantage. Secondly, the differential exposure to adverse life events, which is often quite strongly associated with particular social and economic arrangements. And then thirdly, the specific conditions of vulnerability or resilience that these arrangements and exposures produce. So it's really often a combination of differential exposure to worse and more frequent adverse life events with a disadvantaged social and economic position that increases risk for mental disorders. And in this paper, we developed this conceptual framework, which, as you can see, covers 5 main domains of the social determinants of mental health. First of all, the demographic domain, then the economic domain, the neighborhood domain, the environmental events domain, and then the social and cultural domain. And what you can see from this figure is that these domains exert their influence on the mental health of individuals across the life course, from infancy through to old age, and that they do this through a number of distal factors, and then also through a number of more proximal factors. So, for example, the effect of economic recessions is experienced and has an impact on mental health through its effect on income, debt, assets, financial strain, and so on. What we also tried to do with this conceptual framework was to demonstrate that many of the United Nations Sustainable Development Goals are very relevant for each of these domains of the social determinants of mental health. Indeed, one could argue that by addressing some of these broader SDG targets, one could potentially have an influence on population level mental health. Now, in the COVID era, these determinants become even more relevant. We've seen between 71 and 100 million people driven into extreme poverty as a result of COVID and the related economic global recession, widening income inequality, food insecurity, and gender-based violence. And all of these are known risk factors for mental health problems. So really, the COVID era has amplified the effect of many of these social determinants, and this is becoming increasingly clear as the research is telling us. So this begs the question and leads us on logically to asking, how do we go about intervening to address the social determinants of mental health, particularly for children and adolescents? And back in late 2019, I was involved with other colleagues in a workshop convened by the Academy of Medical Sciences and the Inter-Academy Partnership on the social determinants of global mental health. And we went through a process of discussing the social determinants using this framework according to these 5 main domains, and then trying to identify intervention priorities by domain. And the workshop is very nicely summarized in a paper by Kelly Rose Clark that was published in Lancet Psychiatry in 2020. And these are some of the examples of the intervention priorities which we might want to consider if we wanted to start to address the social determinants of mental health. Under the demographic domain, the whole area of gender-based violence was highlighted and identified as a potential area which by influencing or reducing, one could influence the mental health of populations, particularly the mental health of women. In the economic domain, social protection interventions such as cash transfers have enormous potential for improving mental health. In the neighborhood domain, urban renewal interventions may have some impact on the mental health of people living in urban areas. In the environmental events domain, improved disaster response might have a significant impact on mitigating the effects of adverse environmental events on mental health. And finally, in the social and cultural domain, interventions that build social capital and trust, that strengthen education, can potentially improve the mental health of populations or provide a buffer against adverse social and economic circumstances. And again, these interventions are quite nicely summarized in this paper by Kelly Rose Clark. So this is all so far so good. We have a number of identified social determinants. There is the potential to try and influence these social determinants and then potentially have an impact on mental health. However, when we start to explore this area in more detail, we quite quickly realize that there are a number of challenges, both for researchers and for research funders, and indeed for policymakers. So one of the first challenges is that of the interventions that address social determinants are quite distal from the mental health outcomes that we hope to influence. If you consider, for example, urban renewal programs, the manner in which urban revitalization or urban renewal might lead to the improvement in mental health of citizens who live in those areas is complex and quite distal, and it's very difficult to show a clear causal relationship between that intervention and the mental health outcome. Secondly, and in a related way, the mechanisms by which particular social interventions influence mental health are poorly understood. For example, if we were to provide cash transfer programs to protect particular populations against youth poverty, the way in which those interventions get into the neural pathways of young people's brains and lead to changes in their mental health status are really very poorly understood. Thirdly, this kind of research really requires interdisciplinary approaches. It requires economists working together with mental health practitioners, anthropologists, social scientists, really thinking together and developing a common language around how these particular challenges could be evaluated and implemented. Fourthly, there are very limited available data sets within low and middle income countries. Very few randomized controlled trials have been conducted in this area. Often we have access to longitudinal data sets, which have been collected in the context of particular programs, such as social protection programs. But again, being able to establish causal relationships between these interventions and the mental health outcomes is very challenging. And in a related fashion, we have limited culturally valid mental health outcome measures across these diverse cultural settings. There are also a number of ethical challenges with implementing these kinds of interventions. For example, if you were to run a randomized control trial of an intervention to reduce gender-based violence, who would form your control group? And what are the ethical issues? There are a number of ethical issues around allowing women who were exposed to adverse circumstances like gender-based violence and withholding an intervention. Next, these interventions require clarity on our conceptual foundations. We need more clarity about universal, selective, and indicated prevention interventions. Who are the target populations? What are the criteria that we would use to identify them? And how might we determine their eligibility to receive particular interventions? And then finally, there are a number of challenges for research funders, challenges around how to support interdisciplinary research. Many research funders fund in silos. They fund, for example, public health interventions, or they fund economic interventions. And in order to be able to evaluate applications for research in this area, funders would need to convene interdisciplinary review panels, people from a wide variety of different academic disciplines who need to reach a consensus around how they would evaluate decisions to fund particular areas of research. So this is really an area in its infancy, and as you can see, there are a number of different challenges involved. So I want to try and suggest, in the time remaining to me, some potential approaches that we might wish to adopt. I believe the first step is to try and build theoretical models, to really try and develop a more robust theoretical understanding for how we think particular social determinants lead to particular mental health outcomes. Secondly, we need to then test specific mechanisms in hypothesized causal pathways. So we need to test how a particular intervention might influence a particular mechanism, which might in turn lead to a particular outcome. And third, we need to pool data across multiple sites if we are going to really have adequate power, and also to understand how context influences these interventions. So let me give you an example of how this might work. If, for example, we were to plan an intervention to deliver cash transfers for refugee youth, the potential mechanism by which this might lead to the prevention of depression is through neuropsychological mechanisms of self-regulation. We might hypothesize that youth who receive cash transfers develop more capacity to regulate their own emotions because they have some level of financial protection, a buffer against their adverse social and economic circumstances. And this in turn might prevent depression. So studies really need to test these specific mechanisms and check whether these particular hypotheses are correct or not. So all of this really requires a high level of consensus on plausible causal pathways and measures. It requires a high level of cooperation and also data sharing across sites internationally. And as I mentioned, context really does matter in this whole area. And thirdly, it requires a high level of interdisciplinarity and people from different academic disciplines working together to solve these complex problems. So before I close, I want to just share with you a couple of examples of studies that I'm currently involved in, which are trying to do some work in this area. And the first is the Chances 6 study. This is being led by Sarah Evans-Latsko at the London School of Economics. And we're working in 6 low and middle income countries: Brazil, Colombia, Mexico, Liberia, Malawi, and South Africa. And we're exploring the effects of cash transfer programs on youth mental health and on their life chances. For example, their educational attainment, their employment prospects, and their long-term relationships. And in this study, we are utilizing existing cohort data sets from 6 countries to examine the effect of these cash transfer programs on these mental health and life chances outcomes. And we've just published the protocol paper for this study, which sets out the methods in the Chances 6 study. Among other things, we are conducting interviews and focus group discussions with young people, families, and professionals, both recipients or providers of cash transfer programs, to try and understand their experience of receiving cash transfers, what it means to them, and how they think it's influenced their mental health and their life chances. We're conducting stakeholder workshops with policymakers and practitioners in this area in 3 of the countries. We are doing quantitative analysis of longitudinal data sets, including young person participants, in all 6 countries. So we're looking at existing cohort studies and exploring the effects of these cash transfers on the mental health and life chances outcomes. And we're also looking at economic analyses of the potential return on investment of these interventions. And we're hoping that our findings will demonstrate the impact of cash transfer programs on young people's mental health and life chances, some of the mechanisms and pathways to improve mental health and life chances of young people. Thirdly, the return on investment, as I mentioned, of cash transfer programs, and then knowledge on how to design or redesign, implement, or evaluate cash transfer programs. So if you're interested in this, please do have a look at this paper and keep in touch. Our work is really ongoing, and we're hoping to be presenting results in the months and years ahead. The second example I'd like to share with you is from the ALIVE program, and this is focused on improving adolescent mental health by addressing the effects of poverty. And we haven't yet met as a group. We've just started just a couple of months ago, and this is a screenshot from one of our first Zoom meetings. But essentially, we are interested in the effect of multidimensional poverty on both self-regulation and the incidence of depression and anxiety. And our hypothesis is that by potentially intervening to address both multidimensional poverty and self-regulation, we have the potential to prevent depression and anxiety. In other words, to reduce the incidence of depression and anxiety. And in this study, we're working in Colombia, South Africa, and Nepal. And we really are at the very, very early stages. This is a Wellcome Trust Collaborative Award, and it's funded for the next 5 years. Self-regulation is really a key aspect of this. There's been some very interesting work conducted by Palacios, Barrios, and Hansen, looking at the way in which self-regulation is affected by poverty, especially in childhood. And this includes both bottom-up reactive signals and also top-down elements of control. And our hypothesis is that by developing a better understanding of these self-regulation mechanisms and the way in which poverty influences them, we have a potential route to diminish the impact of poverty on young people's mental health and building more resilient young people who are able to address adverse social and economic circumstances. So what are some of the key questions for future research? And I'll be finishing off with this. I believe the current data shows us that there's a huge need for longitudinal epidemiological studies in low and middle income countries to give us a better understanding of the intergenerational transmission of poverty and mental illness, the mechanisms of poverty and mental health over time, and the links between gender, poverty, and mental health across the life course. So this really requires an understanding of the links between genetic, biological, and socioeconomic risk factors. And then we really need to develop the field of intervention studies targeting specific proximal mechanisms, for example, cash transfers combined with psychological interventions, or studies that examine the impact of violence prevention on mental health. We also need intervention studies that target some of the distal mechanisms that I mentioned, like living environments. And these studies really require linking cognitive neuroscience with behavioral economics. So in conclusion, social determinants really profoundly shape the mental health of populations, and it's vital to intervene early to address these social determinants. Despite the challenges of intervening, I think there are many opportunities, and really research needs to identify mechanisms and intervention targets. We need to develop more interdisciplinary approaches. We need more community participation and empowerment programs, and we must have commitment from governments, private sector, and international development agencies if we are to come together to address these challenges. So I just want to thank the funders who've supported this work, as I have them here on this slide. And thank you very much for listening. I look forward to engaging with you further and hearing any comments or questions you might have. Thank you.
Thanks, Crick. And I think that's been a great opening to the conference. It's interesting when we think in terms of early intervention in mental health, and particularly given that we know the onset of mental ill health for people is predominantly in adolescence and early adulthood. And we know too that most of the people who are in that age group live in low and middle income countries in the world. That there's a dearth of research addressing that group of people. And so it's been absolutely fantastic to start the conference with your talk. While we wait for some questions to come in, I've got a question of myself. I've got a question myself for you. And that is, one of the things that really occurred to me listening to you was the implication of what you said being that we need to be more rather than less multidisciplinary in what we do. And I wonder if you could speak a little bit about the experience of having to work alongside, people from backgrounds that we would not traditionally work with, particularly in high income countries in mental health. So, I'm thinking about, say with the cash transfers, I imagine there's financial institutions and those kind of people involved. It's multidisciplinary beyond what that usually means. And I just wonder if you could talk a bit about that experience.
Yeah, thanks, Ewan. It's a great question, because I think this addressing social determinants really requires us to be very multidisciplinary and in fact interdisciplinary in the way in which we work. So, some of the challenges which arise are around developing a common language. For example, many development economists and behavioral economists speak about non-cognitive skills. And for us working in mental health, this is what mental health is all about. It's all about non-cognitive skills and how we understand our emotional worlds and how we make sense of them and how we develop interventions, especially for young people, that are appropriate for them and meet their emotional, behavioral and cognitive needs. So I think, the way to go about this is to form these teams and to work closely with economists and to work out what we mean by these different terms. Another issue that arises is, as I mentioned, is around funding. Often funders work within silos, so we increasingly need to challenge funders to say, can we also bring on board economists into this particular proposal, and do you have economists on your panel who would be able to evaluate the economic evaluation of this particular intervention? And then, the third issue, which comes up quite often working with other disciplines, is around authorship. Typically, economists have 2 or 3 authors on their papers, and they're not very enamored with the idea of having long lists of authors, which we often do in public health and in mental health. So that requires some negotiating. But I definitely think these things can be overcome, and I think the potential benefits are enormous, and we should be doing a lot more of this, especially as we expand our knowledge on the social and economic drivers of mental health in populations.
Great. And I'm just, I would encourage people, apparently there's a ask a question button under the live stream. If people could put their questions into that, that would be really great. Currently, I can't see that. But one of the other things that you mentioned there, Crick, was the siloed nature of funding things. But I'm also struck by the sorry, there's a bit of background noise here. It's the whole thing of working from home. The nationalised nature of funding as well. Often, a lot of funding bodies will only give funding to the countries in which they are. And is that, do you think, an obstacle that we need to be sort of working around with this sort of stuff?
Yeah, that is a huge obstacle. And I think especially for working in low and middle income countries, most of the national funders within low and middle income countries just don't have the kind of budgets that we need to do these large studies. So typically, most of the research that we've been involved in low and middle income countries, including Sub-Saharan Africa, South Asia, and Latin America, has been funded by high income country institutions and organizations like the Wellcome Trust, National Institute of Mental Health, DFID, or what's now called FCDO, the European Commission. So it requires researchers in low and middle income countries to approach these and to find partnerships with high income country institutions often to conduct this kind of research, which is really challenging. And I think, a crucial area going forward is that we need national governments within low and middle income countries to be better resourced to conduct research. And they need development assistance really to build their own internal capacity for mental health research. So I think this is a really vital area, and we must move across national boundaries. I mean, these are global issues. They affect us all internationally. Issues, for example, around migration and the way in which migration influences the mental health of populations is huge, and it must require international collaboration to address.
I've muted myself, sorry. I was also struck by the number of people who were moved into poverty by COVID. And I wonder if you have some thoughts about the sort of medium-term implications of that in terms of, the burden of mental health and other issues in low and middle income countries particularly.
Yeah, so there's a fascinating paper which was published just last week in The Lancet looking at increases in the prevalence of depression and anxiety disorders due to COVID. And the two main mechanisms that were identified in that paper were a fear of infection and infection rates and social isolation. But I think a big driver behind all of this is the economic drivers related to the global recession, massive growth in unemployment. And we know unemployment and economic shocks like loss of employment are strongly associated with suicide rates. So I think we're yet to see the full consequences of the economic impact of the COVID pandemic, especially in low and middle income countries. And I think, when we talk about improving the mental health response to COVID, often what springs to mind is establishing counseling services and mental health services. And certainly a lot of countries are doing that. But I think we also should be looking at ways to pair social protection interventions with these mental health interventions and to link, for example, cash transfer programs with vulnerable youth with mental health conditions, I think would be a way forward for this.
I'd just like to say to everyone, apparently the ask a question button has appeared. If you refresh your live stream thing, that should be there now. It'd be great to have your questions. I know that Alison Young, who's co-chairing this with me, Alison is the president-elect of IAPA, has a question for you. She's popped it in our chat, which I'm not sure that everyone can see. But Alison, if you're there, do you want to ask this? Or I will try to ask this question for you. You can tell me if I'm wrong. But basically, I think Alison wanted to ask a question about advocacy for tackling poverty, gender-based violence, and climate change. And should this be a role for organisations like IAPA?
Yeah, I think it's a great question. I really agree. It should be part of what we're trying to do as people involved in mental health and especially involved in early interventions. I think early interventions shouldn't be restricted to clinical interventions. We need to be thinking about interventions that address the social and economic circumstances that young people live in. And so issues around gender-based violence, child maltreatment, poverty, food security, these all have a huge impact on the mental health of young people, as we know. And so we need to broaden, and I think this is what I'm trying to convey with my talk today, is really broaden the remit of what we understand by mental health interventions and early interventions to include social and economic interventions. The challenge, as I think I was saying earlier on, is that we don't have a very good understanding of the causal mechanisms involved. But some just make intuitive sense. And, for example, gender-based violence and child maltreatment, we know that they are strongly associated with subsequent adverse mental health outcomes. Why should we not be doing more about these things?
Makes complete sense to me. And I wonder too if in many situations, because there are so many of these different social determinants, that often it just seems very beyond possible to address, and I wonder if sometimes that actually contributes to their allowance to going on, or the fact that so many people experiencing this kind of like a communal acceptance that that's just normality. I don't know what you think about that.
Yeah, I think that really is an issue. And I think what we need to be doing is to be looking carefully at where we can intervene. And often it may be at a more proximal level. So, for example, I was working with a colleague the other day around designing an intervention for men's mental health in Kenya. And we were talking about what are the factors that influence men's mental health and especially influence substance use, and depression. And we talked about financial situations and the potential for including a financial literacy component into the family therapy intervention that she was developing for men in Kenya. And so we're looking at how we could integrate this financial planning or financial literacy component into the family therapy intervention that she is developing and evaluating. So I think it's about, and I think there's potential for more work to be done in this area, and that is, how do we make decisions? How do we make choices about the most appropriate social determinants to address for a given situation, a given population, and what is feasible, both in terms of what we can afford to intervene with and in terms of potential mechanisms to impact.
Okay. Now, I'm just been prompted to remind people that if you can go to the button, the Ask a Question button, which is under the live stream, you should be able to ask. Oh, actually, I can see some questions here. Sorry. So there are examples worldwide of individuals being stigmatized, exposed to more adversity or threat by being involved with external Western agencies. How do we tackle this?
It's difficult to know the context of the question. Stigmatized in what sense?
They've given an example of Muslim communities in Pakistan. It's a person, Richard Whale.
Right. And so the question is about, can you just clarify the question a bit, Ian? Sorry, you probably did.
That's okay. I'm just reading it. It says there are examples worldwide of individuals being stigmatized or exposed to more adversity or threat by being involved with external Western agencies. I'm not quite sure what but one of the things I suppose I would say is that, or would ask, is that I know that for a lot of people in low and middle income countries, stigma is a very real obstacle to seeking help. And maybe if we look at that more general issue, if you have some thoughts about that.
Yeah, I mean, I think stigma is a huge issue for mental health, especially, or not only in high-income countries, of course, in low and middle-income countries as well. So we've done some work in this area in the PRIME study, and Brandon Court really led this, which was to integrate training of primary healthcare workers, integrate a stigma reduction component to the training of primary healthcare workers in Nepal. This is something called the Reshape intervention, which is now being evaluated in a large cluster trial in Nepal. And simply put, the strategy was to ask people with lived experience of mental health conditions to tell their stories to the primary healthcare workers in the context of the primary healthcare workers receiving training in MHGAP. In other words, integrating a stigma reduction component into primary healthcare worker training. And it was found, at least in the pilot study, to be really completely feasible and acceptable. It was, in fact, very empowering for the people with their own lived experience, but also seemed to indicate an improvement in detection rates and treatment provided by the primary healthcare workers. So, again, I think stigma is such a vital issue. We should be really integrating it into our interventions and thinking about it very proactively, thinking about the mechanisms, how it would work. And the best evidence is for people with lived experience to share their own stories and for personal contact with people with lived experience of mental health conditions.
Well, thank you, Crick. And look, I'm again so pleased that you were able to kick us off over our 3 days. And I look forward to what the rest of the 3 days has, but it's been an absolutely fantastic start, and thank you for helping us do that and for giving us the content of your presentation today. Thanks very much. If we were here now, we'd give you all a big applause. I'm sure people are applauding around the world. For everyone else, we're going to have a 5-minute break now. After the break, we'll be in room 2, so please come back to that through the main part of the platform, and I will see you in room 2 in a few minutes. There's also the virtual platform and the IAPA exhibitor booth if people want to do that in these 5 minutes too. Again, thank you, Crick, and we'll see everyone in 5 minutes. Thank you.
Thanks, Ewan.